So I often say, I've been in newborn screening for over 20 years. I always like the slogan, simple, elegant. So allows you implement in a public setting, scalable, and also do not artificially get things more complicated you need to. So we'll see. So my point of view may be a little bit different. And so the title is more provoking, right? Genomic sequencing newborn screening, what it is and what is not. So let me get things started. So hope next 10, 15 minutes, I was able to address a little bit about newborn screening in the context of public health. And the second is genomic sequencing in the context of public health screening get more detailed. And the last but not least is the ethical concern around genomic sequencing. What is the smoke? What is the fog? So we need a sorting out before we move forward. So this is my favorite slides. I don't know how often I use it because I always want a reminder in the public health setting, it's not in a research setting, what we need to do. So we have a lot of work to do prenatal, the education, then we need to address how specimens get in the laboratory so we can do the timely testing and reporting. And then the laboratory testing. With today's context, I will emphasize laboratory testing. Then afterwards, your work is not done. You be sure the confirmed test being done, kids are under proper clinical care, and furthermore, is a long-term follow-up, which is really is a societal benefit, how the cost effectiveness. So come to the genomic newborn screening. I want to say we already have some since the foundation be built. So this slide actually is several years ago, I was invited to give writing a review paper, and I realized how little is in the literature. And basically, we end up using our own experience, summarize what's being done. Couple things I want to mention to here is next-gen sequencing technology is not new anymore in the public health. And we started to 10 years ago for the cystic fibrosis. The reason is you can relate it to is because CFTR gene is so big. So any conventional technology cannot simultaneously screening the large panel. So it's why we utilize that. Allowed us to have some kind of experience with DNA from dry blood spots and also how you do the tiers to get over the need. And I think we learned from that early on so we can going forward. So this is quite a bit of things that happen in the United States already in terms of utilize next-gen sequencing. And this is, to me, this is a pretty foundation in public health. We need to understand newborn screening is not diagnosis. Newborn screening is a risk assessment. Given that principle, when we report screening, we either screening negative, this we always hoping for, and the screening positive, which is our goal, is identified at-risk children, get care early on. And we also have this scenario. You start with certain threshold, and you have some results, doesn't seem to fit in the pattern exactly, but also you don't feel comfortable, say, screening active, so we put it in the borderline. In that situation, we don't refer to clinical care. What we do is ask a repeat newborn screening. The reason I put it here, I kind of fit in the genetic screening too. You don't, certain variants you may not have 100% the confidence is why this likely pathogenic can fit in the category. And also because you do the genetic testing, you may encounter the carrier. So interesting part is, example here is sickle cell disease. We can avoid not to see the carrier. Actually, we report out. And the cystic fibrosis, if we're not confident we cover all the potentially disease-causing variants, when have a variance, one variance identified, we still say possibility. But I think going forward, actually, we can enhance this kind of the conclusion, make things better. So another category we said screening conclusive usually be utilized in the screening, the specimen to the quality you have in question. I think that can be utilized in the genomic sequencing for newborns. And I think it's the important things because it's a screening. So we, in our report, we have every single report, we have this disclaimer. The screening negative, if a clinical indicated, you still need to think about the condition. I think it's relevant. So what I'm saying here is the current structure, the thought process can be utilized in the genomic sequencing in newborns. It's why my mind, I put a technology piece. So given that, what we need to think implementation piece. First is why, right? I think we talked so much already. And from laboratory testing point of view, I really think the genomic sequencing in public health, newborn screening, really opened the possibility and the opportunity for us to meet genetic screening needs. We talk about the therapeutic development, the platform in place, and if you screening one disease at a time, you will be way, way behind. So that's, we need a rethinking how we do that. Second part is, because the genomic-based sequence allows you to have a flexibility. When you understand disease more, when you have a new therapeutic, you don't need to go back, we call the wet lab piece. You can just change the interpretation tool, we call the dry lab piece, can allow you going forward. When you use the laboratory, you know how this validation process can be very daunting. Last but not least, I want to mention just the people comments make me think. So we talk about monogenic disorders, but we also know have a genetic modifier. So the more we understand, if we have this genome based, we really can be more precisely diagnosis, prognosis, and choose the treatment. So first, I have a group in terms of from a laboratory screening point of view, what things we keep in mind. And we talk so much about that in terms of what condition. And I think it's very important as a public health, not a research setting, the urgency is very important. And because we need to keep the principle, think about the onset during the time. We heard 5 years, in my opinion, I may be shorting a little bit more. It's really is a newborn screening become the only avenue people want to do things. But I think the genetic is a lifelong time journey. We need to think about newborn screening, childhood screening, adult screening. So I'm saying that, and the severity. And this can be objective, right? So, I mean, subjective, but I think it's important, it's mortality and mobility, lifetime, this I can be seen, and treatable. It's another area can be argued. We talk about a few getting better, but I use this very often. When a genetic condition have a transformative treatment, newborn screening is undeniable. So I'm not elaborate more, but we can discuss more. So another thing is interesting, I haven't heard very much, is even you have a good biochemistry marker, but I think the additional genetic testing can help for giving we are in the era more genetic testing. And like CF is a modulator, you want to know exact genetic change, so that's can be helpful too. I'm big, stronger believer is do not report the variants with unknown significance unless at the screening the time you can use a biochemical marker to verify at the beginning before you report out. And also do not report a carrier. So a lot of argument can be, benefit, but at this stage, I would like to set a bar very high, and you have to think about the net benefit. This, in other words, I haven't heard yet. I want to say that because in time I can do more, because one thing is not just black or white, you do the comparison. And remember, we heard so many times, first, do no harm. So that's not only we talk individually, we talk about population. So keep this in mind. Wow, my time is up now. Talk about method. I feel like I need to hurry up. We still need to worry about get sufficient and good quality DNA at this stage. And we heard about the long reads and the short reads, the benefit and the cons. And not only we select disorders, I think it's important we'll select the variants that have to be pathogenic. And I'm even questioning about likely pathogenic. So we have more discussion. And come to implementation and scaling board, I think we heard so many things. And I just want to emphasize the last one, federate national infrastructure. This is, I'm targeting US. So I think we need to learn from each other. We learn together. And this is the iteration in my head. And of course, a lot of nuance be in that because I think be successful, we have to work together. And I put these slides on the later on, it's not important, but I put it here more later is because if you really structure public health genomic sequencing, certain things we worry about may be moot. That's what I'm hoping. That's what the words smoke or fog come to place. Sorry.